So, sorry. And one of the reasons was because there's so many myths or sort of untruths around children's palliative care, what it's about, why certain people think it should be offered at only a period of a person's life. So let's have a look at some of these myths that we have. And often, and I think this is one of the biggest ones that we come across, that people say, well, palliative care is usually for children with cancer, or palliative care is only for children needing end-of-life care. And sadly, these really are myths. When we look at the need for palliative care, and I mean, if you can picture that slide yesterday with the need and how many children were actually receiving palliative care, these two myths are two of the biggest contributing factors as to why that need is not being met. So which children do need palliative care? Yesterday, Julia spoke a little bit about it, and I'm just going to say that palliative care is appropriate for any is appropriate for any child, neonates, babies, toddlers, school children, adolescents, and even young adults living with serious, life-limiting or life-threatening illnesses. And in South Africa, a child is recognized as anybody up until the age of 18 years old. So any child can fall into the category of us giving and offering palliative care to them. Okay, yesterday Julia spoke about the different categories, the ACT categories, and how we look at children and we classify them and we put them into categories according to the illnesses or conditions that they have. And when we looked at these, it was a proposed grouping system for life-limiting and life-threatening illnesses. And similar illnesses are grouped together, and grouping was also largely based on the different illness trajectories or pathways that that condition or illness was likely to follow. And this is just a slide that condenses the different 4 categories that we looked at and their expected trajectories. And as you can see, they really, really are different. And it's important to recognize and understand these trajectories too, because the type of care that's going to be provided is going to be dependent on what trajectory we expect that child to take with their condition or illness. And then moving on from offering children's palliative care to children, when we looked at the slide yesterday with the need for children's palliative care and the conditions that were receiving palliative care, if you notice the 2 circles there, I've circled premature birth and birth trauma and congenital malformations. And with the advancement in technology and early scans, 22 weeks diagnoses being made of congenital malformations early in pregnancy, lately the interest is a big interest in offering perinatal palliative care to these mums where diagnosis has been made in a pregnancy, or there is a premature delivery of a child that condition might determine that they might not have a good prognosis or expected to live a long life. And so when we look at what perinatal palliative care, it focuses on assisting families in especially decision making, because often the question is presented, do we terminate a pregnancy or shall we allow this pregnancy to continue? And with being able to offer perinatal care to these parents, we're giving them a different choice. So perinatal care is definitely at the forefront of where we're going with children's palliative care at the moment. And excitingly for us in Patch, we've heard that we've secured funding for a new project for the next 3 years, and we're going to be developing a perinatal care better care book and a perinatal palliative care online course So that's where our focus is going to go for the next, into the next 3 years. We'll continue with children's palliative care, but that was just very exciting news for us, and we're really looking forward to being able to offer knowledge and experience and education in children and neonatal and perinatal palliative care. Let's move on and look at some of the other myths. So we spoke about palliative care yesterday, that one of the things that people think it's palliative care only starts when curative treatment stops, and that it means giving up hope. So when we hear say, well, there's nothing more we can do, we have to now offer palliative care. We've done what we can, it's time for palliation. And those two are really very big contributing factors to why there aren't services being offered. So let's look at the model of palliative care. And when we look at the different areas, we look at curative care, we look at palliative care. And when you look at the two, you can see from diagnosis that palliative care might be minimal, but it can be offered from the time of diagnosis. And even though that care that might be offered is very little, it could be just psychosocial support or spiritual support, at the same time, curative care can still be offered. And as an illness or condition progresses, and maybe the prognosis changes or the complexity of the illness or the condition advances, so you could see there will be the opportunity to offer more and more palliative care, and then curative care might be then decreased. And if it gets to the stage where curative treatment is now becoming futile or not working, and a decision is made to stop with curative care, the palliative care is there to support that family, that patient right through the death period. And then yesterday we didn't speak much about bereavement, but that's one of the biggest areas where we in palliative care work. So when a child dies, we don't leave that family. We support them right through the next couple of months, or however long they might be, into the bereavement period. And we, in palliative care, who we can try and stay in touch with families, offer them support or refer them to support groups to receive bereavement care, to help them through that grieving and mourning stage. Let's look at another couple of myths. So children are just little adults, aren't they? Is one of them. We can treat them the same as we treat adults. And there's no difference. It's just we might need to do a few things different, but generally children are the same. And when we look at children's palliative care, this is not true. So what is different about children's palliative care? Children, we know, are not small adults. They think and behave differently to the way adults do. We know that children develop differently. They've got stages and ages of development. Their needs are unique. Their size, their ability, their understanding of illness changes throughout their growing stages. So we can't put children into the category of being adults as they develop. And also the other thing we would need to think of is children are very dependent on their parents or other adults or guardians, caregivers, whoever's giving them that support. So they need to be included as part of the care, part of the team, the parents. So that changes a little bit to adults, and that parents will have a lot of influence and be part of that decision making when decisions need to be made for children. Then when we talk about communication with children, it tends to become more difficult. And again, children communicate according to their developmental stage and age. And I mean, you know, with small children, we need to get down on their level. We need to be talking to them. We need to be communicating in the language that they communicate. And it's not just communicating verbally. We need to look at their body language. We need to watch their non-verbal language as much as we're looking at their verbal language. And we need to understand how children communicate at these different levels and stages and ages. And it takes quite a bit of skill to understand children. I'm sure many of us here in this room today have got children, and we see how they change, how they grow, and how our communication with them grows. And then another factor that we look at, children are often very afraid of being separated from their families, friends, school, and home. And it impacts hugely on their psychosocial coping methods and how they respond then. And so we need to be looking at this child holistically, all the psychosocial, the impact that the disease, the condition has on this area. Are they afraid? And sadly, in South Africa too, a lot of our children who are admitted to hospitals have families living in rural areas, have to be left alone, are separated for long periods, or moved to stay closer to with other family members to help them treat their conditions. So we need to be very aware of the psychosocial aspect of being separated from their families, their friends. And then children have educational needs and the right to play. And we cannot forget about that. Children have a right to education. They have a right to continue, and they learn through play. We know that play is the universal language for children, and we can't forget that. And there's the picture of the boy. I'm not sure how you see my screen, but that's Nambi in the wheelchair. And he was a little boy who was very special to me. And he had a medulloblastoma, and which then metastasized to his spine. He was treated by Dr. Julia Ambler. She referred him to me. And he was brought back to our area where we live. We live in a very remote rural part at the border of the Eastern Cape and KZN. And we don't have any palliative care services in our area bar me. And she asked if I would be willing to visit the family and support them through this time because of his prognosis being poor. But when I met him, he was this happy, positive boy who just had a zest for life, who just wanted to live with every bit of his being. And when I first met him, one of the questions I asked him was, what do you miss about your life now? And two of the things that came to mind that he actually said to me, I love to play soccer and I miss school. I love school. He was a top performer. He was in grade 7 in his school. He says, I miss my friends. I miss my school. And so with his parents' permission and with him, and we chatted what we could do. So soccer was out. So we organized a basketball net for him to be able to go outside in his wheelchair, got his friends around to play with his basketball. And then we also organized, and this picture was taken on what we call Hats On for Palliative Care Day. We managed to get him back to school. And anyway, we managed to get him back to school for that day. And with that being said, he actually then wanted to go back to school. And he did go back to school to write his exams. He wanted to write his exams. He went, he passed with flying colors. And his mom said to us, we gave him back his life. He got quality of life back. He was in the place he felt belonged. And sadly, he died 4 weeks later. But he died having been offered that right to education and the right to play. So sorry, I had to put in a bit of a story there. I know I'm running out of time. Anyway, let's carry on. What else is different? The drugs used, the dosages, the side effects are often different in children. The ages, the size of them, we have to take that into consideration when we treat them, when we look at what medications we're giving them. And then often their symptoms are vast and they can be very difficult to assess, especially when we're looking at non-verbal children, our toddlers, our neonates, our babies. They can't verbalize. So we have to be able to develop different techniques to be able to assess their pain and symptoms. And then again,
I just came here now because I'm for the palliative care. Okay.
I'm sorry. There's a different spectrum of diseases in childhood, which we know, which will need different type of care, different type of support. So those are some of the myths with children being little adults. And then the other two that we do think about is children's understanding of illness, death, dying are not the same as us. their age, their stage of development, and their experience with illness and death will have a huge impact on how they grieve going forward. And also their parents' cultural ways, that will impact on how they mourn and how they grieve, and it's going to be different. Professionals often find providing palliative care to the child particularly difficult and challenging, and children tend to have a broader range of people involved with their care. And we do say with palliative care with children, the team is who their child needs at that one specific time. The team is going to be ever evolving and ever changing, and it's going to be diverse. And here we're going to see a lot of therapists being involved with child play therapists, music therapists, and I know we've got some karate therapists on the course with us too. And that's where they come in. They're offering that alternative aspect of what a child needs to be a child. And then palliative care services can only be provided in well-resourced settings and only provided by hospices. Well, these are also myths. When we think about it, and we spoke about it, and I'm not going to spend time on this yesterday, where we spoke about where palliative care can be provided. It can be provided at home, in hospitals. And when we look at South Africa, these are the 4 hospices that offer children's palliative care or organizations at the moment. There are a couple more: Sunflower House, PedsPal in Cape Town, Mduduzi, who we had Dr. Julia and Tracy speaking to us yesterday. Then we have Lambano in Johannesburg, and then we've got Footprints with Sam. Come up. Is also there, it's disappeared. And then there are another couple, there's Iris House in Cape Town and Northwood Hospice in PE. So there are a few hospices and support services that are offering specialist palliative care around South Africa. And we would encourage you to find out more about all of these. If you're looking to refer patients, if you're looking for support, you're looking for advice. And again, this is just the European Association for Palliative Care in 2013 said palliative care needs to be offered across a range of healthcare settings, from tertiary hospitals to primary care. And all healthcare professionals and workers should be able to provide appropriate palliative care, and thus be trained to provide these higher standards. And this is why we're offering these courses. We want people to be trained. We want to educate people in children's palliative care. Okay, and then I know I'm running out of time, so I wanted to say in South Africa, we look at different levels of palliative care. We look at the primary level, it's the community level where we can offer a palliative care approach. So it might just be having to offer a bit of psychosocial support, a bit of maybe symptom control management, and or maybe a bit of spiritual help. Then we can look at the secondary level, which is your district regional hospitals, where general palliative care can be offered to children who are being admitted, who might need some pain and symptom management, or there might be sort of a complexity going on with the illness that might be investigated. And then at our specialist palliative care, this is often where tertiary levels, we would look, and this is where we're looking to develop more and more specialist palliative care teams to offer this type of service for complex illnesses, for severe pain, symptom management, and sort of end-of-life care where the teams can't manage them at home or at district level. And then again, there's the increasing level of need, intensity or the complexity. And we need to have this referral system of being able to refer up and being able to, refer, I think my arrows hidden here, can you see it there? Referral down. So we need to develop networking systems. We need to be developing these referral pathways that we can interact, we can communicate with one another. So those myths that it can only be offered in a certain place is definitely not where we want to be at this day and age with palliative care. Melissa, do I have time for a video?
Not if you want me to talk.
Okay, we'll see if we can play it at the end then. Okay.
Perfect.
All right.
How long is your video?
It's about 3 minutes. We'll play it at the end. We'll do it at the end.
Fantastic.
Okay.
Thank you. That was brilliant. And I think so helpful. That's why I didn't want to interrupt you and start ringing bells and things. So Tracy, if you could stop sharing, and then I'll try and share my screen. So this is really the story of Sam, and to try and bring palliative care down to a personal level where we've been talking about case studies, but I guess this is the most personal I can ever get. This is talking about my son, and really why the passion on my heart began for palliative care. And to start, some of you don't know me, I guess many of you don't. My name is Melissa. I studied palliative medicine with Tracy and a lot of other colleagues that we had on yesterday. And my passion for palliative medicine really began when I was asked to give a presentation just after 3 months after Sam died. And when I stood up and started speaking about what we had not experienced, what would have made our journey that much more palatable and that much more kind of bearable, everybody came to me afterwards and said, that is palliative medicine. And I said, but isn't that about death and dying? So the myth that Tracy's just given us, that was the first thing that came to mind. And they said, absolutely not. It's about quality of life. It's about teams walking alongside you. And I remember at that time, my heart just breaking, because I thought, if we'd had all of that, maybe my son Sam would still be alive. So this is really the journey for Sam and footprints for Sam. And we'd love you all to look at our website and share our stories and get more involved. So let's have a look at it now. As I said, this slideshow was normally an hour presentation, so excuse me for speeding through it, but I will give you just a few examples as we go through. So yesterday, Tracy talked about what it was according to the WHO in terms of the definition for PPC, or CPC as it's sometimes known. But I just want to add a little bit of a kind of addition to it. I always think that it's not just about at point of diagnosis, because often children take years and years and years to be diagnosed. So for example, Sam took over a year. So I really believe that as soon as a clinician realizes that a child has got a chronic condition, even if undiagnosed, that's when that team needs to come alongside. And remember, it's the two happening in parallel. It's not one or other. And I think that's always key. I always see it in doctor's notes. I see it in kind of how people run in terms of what their hospital terms and conditions are and the policy frameworks, where it's just for palliation. And for me, we really need to look at how do we adjust that language, because it's not about just for palliation. It's about and palliation, that bridge we talked about yesterday. Really, palliative care for me improves the quality of life in patients and that of their families. And this is also part of the WHO definition. So just to run through the principles quickly, just especially for those that weren't here yesterday, it affirms life and regards dying as a normal process. It neither hastens nor postpones death, and this is very, very important. It provides relief from pain and other distressing symptoms. It integrates the psychological and spiritual aspects of care and offers a support system to help patients live as actively as possible until their death, as that lovely example that Tracy gave with the lovely young soccer player. And it offers a support system to help patients, families, and cope during the patient's illness and in their own bereavement. And I think this is so important. I had a conversation with a family the other day. Footprints for Sam does support for families. And the mum said, if I choose palliative care, am I giving up for my child? Am I saying that my child is now going to die? We're going to switch everything off. And that's not the case. Yes, that might be the journey, but remembering back to the disease trajectories that Tracy spoke about, sometimes that chronic journey, we might think, gosh, this child might pass away tomorrow. But often it's long term. And that's why the conversations have to start really, really early. Because if they do, we're not talking about the death, we're talking about the plan, we're talking about the quality of life. And if we bear all of that in mind, then it's much easier to manage. And then when we do get to end of life, we're all dying, that's the one thing for sure we know, then we know that there's a plan, and that when the worst happens, we're not as emotionally in turmoil at that point, because we've had the plan, we've had the conversation. And most importantly, as a family member being part of that team, then we have a voice. And sadly, during Sam's journey, that was one of our huge problems, is we felt that we had no say and no voice, certainly for the first 13 months of Sam's journey. Then also essential parts and components of palliative care are symptom control, effective communication. This I cannot state enough. We need to have a lot more modules in our education system in terms of how to communicate. Rehabilitation, continuity of care, so important. I always see it as really handing over that if you think of a runner, and having over that baton as they go on their relay race. Terminal care, support and bereavement, education and research. So really bringing that continuum of care into front of mind. I just want to bring to mind, you know, when I think about palliative care, I think of an amazing quote from Richard Raw, because for me, pediatric palliative medicine is about the heart. So what does the heart bring us if we actually do abide in the heart? If we just let ourselves be still, to be present, to be here, we feel this exquisite sensitivity and delicacy. It's like the body establishes, I am here, and I exist. It brings me to the sacred now moment. The heart then tastes what's actually here. With exquisite awareness, the heart knows the taste, the fabric, the texture of this moment. The heart is the knower of truth. When there is a true moment, when someone is being authentic and real with you. So being in touch with the heart tells us the quality of our existence and tells us how we recognize the truth. This is what palliative medicine is all about. It's about humanity. It's about the heart. And through Footprints for Sam, we talk about the Samuel generation of healthcare. And I'd love to welcome you all into that space, because what it is saying, yes, we've learned, we've spent years and years studying, and maybe along the way, in terms of being clinicians and nurses and allied professionals, we've had to put up boundaries to protect our hearts. I'm inviting you to bring your heart back in, because that's what we're saying. By bringing your heart in, the research shows, by leaning in, that's when you are less in danger of suffering from burnout, compassion fatigue, moral injury, all the things that are plaguing modern medicine today. So I want you to think about that. Important to have healthy boundaries, but not to lose your heart. And the way you protect your heart is by getting to know your patients, getting engaged, including the families. And this is what palliative medicine is all about. So when this is present, you are more aware of who you're with. And this is authenticity in healthcare. And this is when we sit down with our patients and hold their hands. And this is really, when we say palliative medicine, I don't want you to see the Grim Reaper. I want you to change that perception. Yesterday, when we took the poll, 91% of those respondents said that they'd actually shifted in terms of their positivity towards what palliative medicine was. So I hope that this really helps to give you that picture. So PPC to me is about the meeting of hearts. It's heart-centered and human-centered medicine and care. It's about children with a chronic illness truly living. It's not about dying, and that is the myth that needs to be debunked. It's about turning not viable for life into viable for care, because every child has the right to care, even if that is a beautiful death. And it's about giving a patient and a family a voice. It's about self-care for families and the health professionals that serve them. And it's about holistic care. It's about planning, having a care plan, as I mentioned earlier. It's about good communication, and this is so important, mutual respect and teamwork. And yes, when end of life comes, then it's about dying, but dying prepared and beautifully supported. It's about dying in a planned and considered way, and it's about helping the dying to transcend this world with peace in their hearts, and helping those left behind to have peace too. I want to repeat that. It's about helping the dying to transcend this world with peace in their hearts, and helping those left behind to have peace too. When our son died, we had no peace. There had been no plan. Sam, after 13 months, so our son for 15 and a half months was stuck in hospital in ICU, and he never came home. He never went out to play. And that was what broke our hearts, because when he died, he was 2 weeks from coming home. But because there hadn't been a multidisciplinary team that also included us and our rights and our child's rights, our voices were not heard, and we were not left with that peace. We were left with a lot of guilt, a lot of heartache. And that's why I really want to say, sit down, have a team around you. We don't know everything. That's why it's so important to work as a team. And that is one of the main principles. Oh, I'm losing my voice. The main principles of PPC. It's about hope and dignity and saving lives, and obviously better patient outcomes. And even if that is death, again, I refer to that strange oxymoron. It can be a beautiful death. Sam's death was not beautiful. Subsequently, we've worked with patients where the death has been beautiful because the parents have been prepared. They've been able to play the music they could play. And even in government hospitals where there is a lack of resources, we've been able to make it beautiful. We've been able to give time to say goodbye, something we never had. And it's not just about cancer, as Tracy said. It's an approach for all chronic and rare conditions. Your heart applies to everybody. And early intervention, I can't really mention this enough, is key. So be brave and have the conversation. And in the beginning, if you don't want to have it alone, bring a specialist alongside you, do some role playing. We can train, we can help you with those conversations, but they must be had, because otherwise it can be a gruesome, gruesome journey, a lonely journey, and a gruesome death for that child, and a whole lot of guilt and complicated grief for the family thereafter. So this is Sam, my beautiful little boy. He would have been 6 in April this year, and there isn't a day that goes by when I don't think, what if? Predominantly because since Sam died, I made it my mission in life to learn. I studied palliative medicine. We started 6 months to the day that Sam died at Red Cross where he died. And I at the time thought, I'm absolutely insane. But I remember being invited up to one of the wards, and Sister Jane Booth, who was very much part of Sam's journey, said to me, I want to show you this child. And there was a child with a tracheostomy, must have been literally 2 or 3 weeks old, at his mother's breast, being breastfed. This was something I never got to do. It was something never offered. We were never offered a journey plan to get Sam home. We were just told home was a swear word. Had the conversations happened very early on with Sam, I believe that he might well still be alive, because we have got children home very similar to Sam within 3 to 6 months, and they are thriving because they have been allowed to go home. They've been allowed to have quality of life. With Sam, he wasn't offered a trachea in the first 13 months of his life. Tracheostomies, and I know that there are many, many, many professionals who don't believe this, but I am testimony, as are many of the patients through Red Cross and through some of the hospitals I work with. Tracheostomies save lives. They give children quality of life. And Sam, when he got his trachea, became an absolute, just transformed child. He could eat, he could move, he could taste food, he got his voice. It was the most exciting and empowering thing for him. So excuse me now, because I'm going to have to skip through a whole lot of slides, but I have covered a lot of this. But by the time Sam died, he'd literally had over 100 x-rays. He'd had so many interventions and blood transfusions. And he did, yes, he had a muscle myopathy. But we often wonder how much of that was his journey and how much of that was his myopathy. So I just want to quickly go back here. So if we look at the principles in context of Sam, I'm going to go through it quite quickly because I've literally got 4 minutes. It affirms life and regards dying as a normal process. When children are born with a life-limiting or life-threatening condition, they're still worthy of the best care possible for however long that journey may be. Again, those disease trajectories are unpredictable, and children have the right to the best possible care. Holistic care. Remember, mind, body, and soul. It's not just about the clinical symptoms. We need to look at the whole person and the whole family alongside them. And with Sam, right from the beginning, we were told not viable for life. And I want you to think about what that means, because how do we, if we set our intention as not viable for life, is there then purpose to cure or purpose to help and heal? Probably not. So how do we set our intention for that child and walk that journey with them, even if we know death is probably the end, but it can be a beautiful, beautiful end. It neither hastens nor postpones death. Again, I gave that example where the mom said, am I then literally killing my child? No, you're giving your child quality of life for as long as we can. It instead supports quality of life. For Sam, if he'd had a tracheostomy much earlier on, his quality of life would have been completely different. It prevents nosocomial infections, or it might assist in reducing them. When I'm talking about ventilator here, not palliative care. And it could be argued that because we didn't have a paediatric palliative team, that this hastened Sam's death. So that honest and early conversation about death are truly important. But remember to have them in a compassionate and caring way. Not to go, Melissa said I have to have this conversation, and to go in and literally stampede over the family. No, it has to be, there has to be a warning shot. There has to be a very good conversation. And then it integrates the psychological and spiritual aspects of care. So meaning and purpose, connection to others, the world around us, and the significant and sacred. Emotional wellness is important. Support and hope. And there has to be a sense of safety and security. And again, mutual respect and dignity. Having a voice, allow the parents to have their say, allow the nurses to have their say. They're with the child 12 hours a day. If I have to hear another, so I do a lot of debriefing, and staff so often, I've heard it over the years, I've heard it internationally and locally, where nurses are told, I haven't seen you in the medical halls with me. And I really want to say, think of our language. How do we talk to people? Parents are sitting at the child's bedside 12 hours a day. The nurses are there. So sometimes forget the files and look at the child. Look at the nurses. What are they seeing every day? What are the parents seeing? And take real heed to that. And as a parent, we often felt that we couldn't help Sam. We couldn't protect him. And that was really disempowering. It offers, we've talked about quality of life. Also helps parents understand the non-negotiables for the child and the family. So ask families, ask those questions. Being Mortal is a wonderful book as a guide, what questions you can ask families. That's predominantly for adult palliative care and for end of life and hospice care. However, it's such an important question. What are your non-negotiables? What do you want? What are your values? What is it that you want to live and do with this child? And obviously then try and assist that as much as possible. For us, Sam was in jail, as were we. And his death was sudden and soul-destroying. I'm going to move through some of the big lessons, because this is the one that I really want to talk through, is the disease trajectory of a child suffering from a chronic illness is often long and unpredictable. And that is why having a pediatric palliative team alongside that child and family to walk the complex road together with them and their families is essential. It is essential. So I want you to remember that, to forget the language of just for palliation, and remember that parallel road of walking together. So a final few thoughts. In life, I truly believe we are building legacies. These legacies can be mediocre, pretty good, or absolutely incredible and awesome. They're measured really on how we have impacted others in a meaningful or senseless or uncaring way. As health professionals or allied professionals, one has to ask, what am I leaving behind with each patient and parent interaction? Destruction or hope, pain or joy? And I know when often I speak to health professionals and they go, oh, I don't want to give false hope. Hope for a parent, whatever the kind, is so important. We just have to frame it in the correct language. So let's lose the term just for palliation, because it really is so much more. Having a pediatric palliative care approach to care, even in the most dire of situations, one's legacy and one's heart will be secure, because patients and those cared for will always feel that they have truly mattered, that they have truly mattered. For palliative care engages your heart, and the heart, I believe, is what truly sees and what truly knows. So thank you so much for listening to Sam's story. I hope that this real world example has brought pediatric palliative care, just to the forefront, and to really realize that it's not the scary ogre, grim reaper. It is, as Tracy said, so very much more. So are there any questions at this point? Time, not too bad. We're now going to go into breakout rooms and just give you the opportunity to really study a case and talk about a case. So Tracy, I'm going to ask you to come back in and just to talk through the case study. Are you there? There she is.
And I just need to share my screen.
Okay.
Sorry. Can you see my screen?
We can.
Okay.